Welcome everyone to our monthly webinar on trending beyond COVID-19. This is Karen O'Hara, Director of Marketing and Communications with WorkCare. We appreciate you joining us for our monthly session, and to those of you who've been attending regularly, welcome back. If you're new, we're happy to have you. During the webinar, you'll be on mute. Please submit your questions using the Q&A function in Zoom. Because we go for a full hour now, there should be plenty of time for questions at the conclusion of the formal remarks. We're expecting quite a few questions today, given everything that's been developing on the COVID landscape in recent weeks. The webinar recording will be posted on our YouTube channel, and a transcript of the QA segment will be posted on our website within a few days. During the webinar, we'll post the links via the chat function, so you can find the links to those two files. In the interest of time, I'm going to just turn you right over to our speaker, Anthony Harris, MD, MBA, MPH. Dr. Harris is board certified in occupational medicine. He is WorkCare's Chief Innovation Officer and Associate Medical Director for on-site clinical operations. He's also our lead clinician for our COVID-19 response, and I think he's been busy doing research on the D variant and other developments, so we're looking forward to today's session. Thanks a lot for joining us.
Excellent. Thank you, Karen, and thanks everyone for joining us again on this journey as we continue to deal with COVID-19. Obviously, we are all too familiar, unfortunately, with the trend of increasing cases in the US and globally. We're going to dig into the details of such. And today is all about dealing with Delta. And so we really want to focus in on what are the solutions, what are the tactics, what are the trends that we see in the marketplace that are going to be effective at helping protect our workforce. So let's jump into it. We know the format for our presentation. Clinical business case comes first, talking about what trends are going to impact our business. And we'll get into the causal examination by updating our trends globally. That's a little bit of a change from last month. We kind of flipped two topics around. Thought leadership comes next in terms of what are we anticipating in the US and abroad regarding how we have to frame our mindset first and organize our organizations to be ready for what's next. And trending the pandemic is the deep dive now. That's the other flip here into the why behind the trend. And we'll then talk about briefly the mechanism of the fix. In this case, it'll be the most succinct part of our presentation, but you'll understand why as we get into it. And finally, the messaging that we need to carry forth with our workforce so that we can really connect with our workforce, get high engagement, and hopefully much better engagement than we've been able to do so far around protecting the workforce against COVID-19, the Delta variant rather. So our business case for today, pretty straightforward, but you never want to say, I told you so in a presentation. So I won't, but we want to reflect back to last month where we told you that don't vary from your precautions because the Delta variant was growing. And at that point in time, we talked about how to approach a total worker health mindset from an EHS perspective and why it was important to do so as it pertained to COVID-19. So today, we are specifically talking about a mandate for the vaccine in the workplace. Why you should require the vaccine in the workplace to protect your workforce from morbidity, mortality, and also business risk, okay? And we'll talk about all three of these points here today in the presentation. As we looked back to last month, we were still trying to understand the Delta variant impact, right? We knew that Delta variant showed resistance to vaccination. We knew that the Delta variant had a double mutation, causing it to be more virulent in terms of infectiousness. And we saw reports way back in April of the Delta variant growing from India, originally discovered, and in the UK, right? And we saw that although last month, as we looked at cases per million, we didn't see any tremendous spikes early on this year. We saw in the US, we saw the spikes in India, we saw the spikes in the UK. And so we knew that Delta variant was something that should be taken seriously. Now, with regard to the cause for Delta variant, we want to revisit this, right? We said last month the cause was, and we were trying to understand the variant from a potential impact to morbidity and mortality. So today, it's clear. It's not May. It is causing additional morbidity and mortality here in the US as well as abroad. So as we look to update from an epidemiologic standpoint, we point first to WHO, good publication they've been doing for now 51 editions. This just published this month in August here. And it's a look at where we are globally with our impact from COVID-19. And we want to focus in on the trend that we see globally, with the Americas leading the trend in regards to cases reported to WHO as of this week. As we look at the most recent months here from June up until the end of July, we can see the clear trend that we make no mistake about is associated with the Delta variant, okay? And it would be one thing to, suggest that, hey, we're seeing a spike. It's not as high as it was last year, this time last year, but and if that was the end of the story in terms of cases, right, we may not be having this conversation as focused in on prevention as some would prefer, right? But we have to focus in on prevention because we're still seeing a death rate spike as well. And that's what we want to point out, that it's not just prevention of infections of the COVID-19 virus, it's actual trending upwards of deaths. Again, America's leading the way in that trend. So as we dig into the Delta variant, we want to make it crystal clear that this variant is causing what we feared to begin with earlier this year, right? If we look at the map of Delta, it is global at this point. This is the current summary of Delta based on the actual sequenced samples that have been collected thus far, well over 300,000 sequenced samples. Now, don't confuse that with prevalence, right? In regards to the number of cases, right? We are far multiples, tens of multiples away from 300,000. These are specifically cases that have been sequenced. This is why we know Delta is the cause of the spikes globally, right? If we look worldwide now and estimate the prevalence from a lineage standpoint, cumulatively, we see worldwide Delta variant now makes up 12% since COVID began last year, first in April of 2020 for this particular examination. If we look at the Delta variant attribution cumulatively regarding prevalence in the United States, with California particularly, we're looking at 5% in the US, 7% in California, right? So we want to make sure that we're not mistaken, because there still are misnomers out there, rumors that it's not as significant as in terms of a health impact and spread. And I want to caution you that it is, and we need to be cognizant of it. If we go a layer deeper and start to look at from that global map, the actual prevalence attributed to the Delta variant, right? We can see different levels here globally. If we look at the US, again, we're in that 5% range. South of us in Mexico, they're upwards of 10 to 20%. And we know that morbidity, mortality in Mexico is drastic. And if we look across the pond to our Asian nations, we're seeing prevalence as high as 35 to 50%, in some cases over 80% around India and those Asian nations. So we want to focus in on now the state of the US and update you. As we look back last week, we gave you where the states were in regards to being fully open. A few states, Oregon and New Mexico, Hawaii, that were not open, and those that were pending opening in July. Fast forward to today, all states are completely open, right? Except for Puerto Rico and Hawaii. Hawaii is expecting to open only when, in terms of restrictions in place, fully open when they reach a vaccination level of 70% in that state. So that's the only state that's still holding out with that criteria of 70%. So when we talk about then where we were last month with regard to states experiencing increases in COVID cases, this was the map. It wasn't as sinister as we have come to know it today, right? It was only a few states, California, Washington, and a few others that were experiencing increases in COVID cases. As we stand today, all except one state are experiencing increases, growing numbers of cases. And so again, attributing to the Delta variant and the spread, and I'll keep reiterating that because we know and we'll talk about other variants on the horizon. So Kansas being the only state experiencing shrinking cases. Perhaps we can next month zero in, if that trend continues, as to what's going on in Kansas and how we can learn to trend along with them versus where we're trending nationally otherwise. So let's zero in on our global comparison of where we were last month, right? Daily new on a 7-day rolling average, daily new confirmed cases per million. And we saw what was happening in the United Kingdom. Again, United Kingdom experienced the spike because of their approach to vaccinations, right? We knew that a one vaccine dose initiative that was led by the United Kingdom led to a rapid spread of the Delta variant because of its ability to escape immunity to the tune of only 33% of efficaciousness for a one-dose approach. So as we looked at the impact of the United States, we didn't see what we were anticipatory of a spike. And so as we look at where we're spiking today, we're trending tremendously in the wrong direction, obviously, along with Israel. United Kingdom is starting to come down, obviously restrictions in place there. And so we are going to examine more intimately what is going on with not just the United States, but particularly Israel. Okay, if we zero in on Israel, they're experiencing a similar trend upwardly of cases as a result of the Delta variant. And this is very concerning, and we'll explain why as we go forward here. If we look at the variant, the Delta variant, again, the other name or nomenclature for it is the B.1.617.2. The prevalence there, right, as we looked at it last month, was already over 80% worldwide, right? And we see that trend continuing to escalate upwards towards almost a 90% as we talk about worldwide, 7-day rolling average percent of new cases being positive as a result of the Delta variant, right? So let's look at that more based upon countries. And if we see the sequenced samples and appropriate percentages, again, from UK, the United States to Israel, the picture is clear, right? Canada is not experiencing Delta variant as much, right? And we'll talk about perhaps why. But again, we want to point out that the Delta variant is the cause for the increasing cases that we're seeing. As we look at the attribution state by state of the Delta variant, we can see the states that are the hardest hit by new cases being attributed to Delta. Arkansas, Nevada, Kansas, Missouri, etc. So we can, on the right-hand side, we can look at the positivity of the samples in comparison to all the cases sequenced in that state. All right, and we can see the growing number towards the Delta variant as such. And so again, when I talk about the Delta variant, we have to keep in mind what we presented some time ago, last month included, that WHO is keeping track of the different variants that we've experienced thus far, alpha, beta, gamma, delta, right? We've been talking about these from India to Brazil to South America, South Africa, excuse me, and the impacts, potential impacts we anticipated and what's happening obviously with the Delta variant today. And so as we continue to dig into and examine what should we do in regards to the Delta variant, we have to understand that the Delta variant is one of many mutations that is occurring in the COVID-19 lineage, right? And as we have hypothesized previously, we talked about genetic drift and genetic shifts that lead to new mutations. We are tracking along with the WHO new mutations, right? And these mutations, Eta, Iota, Kappa, Lambda, are new variants of interest. And towards the end of the presentation, we'll talk and highlight one of these variants that may potentially be even more egregious than the Delta variant. But again, these are items that we want to keep in mind, right? Because as we talk about these variants, it's going to be very important for us to simplistically communicate how the virus is going to continue to mutate and impact our workforce, right? And that's part of the messaging that we'll talk about towards the end of the presentation. So let's look at, and Lambda is what we'll refer to at the end of the presentation here. So if we look at the Delta variant, as we talked about it previously, we want to reiterate that the Delta variant compared to the Alpha variant, right, is estimated at 60% more transmissible, all right? When we talk about the associated R0 number estimated for the Delta variant, if you recall, the R0 for the Alpha variant, as we looked at COVID all last year, was averaging around 1.5 to 1.8. At various times when there was high transmission rates in places like New York and California, that number was estimated at upward at about 5, right? A R0 of 5, and that's compared to like the other illnesses like measles with an R0 of 22, right? So if we compare where we are with COVID-19, where we were previously around that 1.8 with the alpha variant on average nationwide, the estimate now for Delta is almost 8 to 11, as high as 11, right? 8 is the conservative, 11 is perhaps where we are with the level of transmissibility for the Delta variant. So we want to keep, again, in mind some of these figures because it will help us compelling our workforce to hopefully get vaccinated with the recognition that transmission and risk is very high for Delta and may continue to increase over time as we look at all the states being open and again, only few states at this point requiring masks for individuals. So when we talk about mandating the vaccine, we want to shift our thinking around why we should require it. Obviously, the straightforward answer is yes, we want to prevent workplace transmissions, right, of COVID-19. But we really want to take a forward look at can we approach this from a total worker health frame of mind? And if we do so, is a COVID vaccine mandate an absolute must in that approach? And obviously, we're saying this because we believe that is the case. And so as we think about where we are historically with our frame of, and perhaps this is oversimplifying, but I want you to think in this simplistic fashion. If our mission as EHS professionals is to protect the workforce from identified workplace health threats, right? Can we add to that, as we've been talking about over the last several sessions here, can we add to that, that mitigation of business risk from workforce health impacts should be our mission. Now, certainly that has been the case with COVID-19, right? We've, in addition to how do we prevent our workforce from becoming infected and transmitted from transmissions in the workplace, it's been very much at the epicenter of our business focus from a risk mitigation standpoint. How do we keep our workforce healthy so that they can remain productive and we can minimize absenteeism? We went into that in more detail last month when we talked about our continuum of transmissions and then framework of prevention of absenteeism, and how we looked at the sequence in which we can be successful at preventing absenteeisms with the same approach or similar approach that we took to prevent transmission, an expansion of, again, our role as EHS professionals. So we believe this will continue to be the lens through which we must look in order to prevent workplace health poor outcomes, as well as maintain a productive workplace. Recall now that the dream of herd immunity is no longer attainable for us, right? We'll point this out more poignantly as we look at those nations that lead the U.S. in immunization efforts. But again, we went through various reasons why herd immunity would not be possible. One of those assumptions around why it's impossible to reach herd immunity rooted in the efficaciousness, poor efficaciousness of the vaccines against the new variants. So given that herd immunity is now not a reality, nor will it be likely in our future, we want to focus in on the trends around the vaccination efforts that continue and how can we attribute what can be a successful strategy in the workplace regarding vaccinations, given the lens, given the background of our status here in the U.S. And vaccination efforts. So last month, we talked about our numbers. We looked at our numbers in the U.S., a vaccination rate of 47.5% for fully vaccinated individuals of the total population, right? At least one dose was 55%. So in the last month, in the last 30 days, we've only moved the needle less than 2%, right? 1.8%. Fully vaccinated is only 49.7%. At least one dose is up to 57.9%. So again, we're not moving the needle anywhere near where we expected we would be from a clinical community or the administration's expectations in the White House of where we would be at this point in time. And there's a lot of concern still yet around where we will end up with regard to our population being vaccinated and out of the susceptibility pool for COVID-19. So recall again, the vaccination efficacy is estimated to only peak out at 37.5%, right? And this is a number that is attributed to the efficaciousness, again, poor efficaciousness of the vaccine against Delta variant. And as we continue through the pandemic, potentially other variants that will arise with similar profiles to the Delta variant. So let's look at a more recent publication. This came July 21st of this month from the New England Journal of Medicine. Again, we want to undergird some of the figures that we're seeing over the next couple minutes here around efficaciousness of the vaccine. Because you will get these questions from the workforce, right? They're seeing the trends of not moving the needle of vaccinations, and they'll also see the efficaciousness being published. And we want to break down and parse out several factors here that's important to communicate to the workforce so that we can still promote vaccinations. Because at the end of the day, when we look at the efficaciousness of our vaccination efforts, New England Journal of Medicine reported for the Alpha variant, for the Pfizer vaccine, we see that a 93.7% effectiveness after 2 doses was expected for the Alpha variant, 88% for the Delta variant. Okay, now that's a lot higher than what we see and what we saw reported from Israel. Israel reported that 39% efficaciousness was the effectiveness of the Pfizer vaccine, right, against the Delta variant. So that huge gap between 2 doses, right, is very important for us to understand. Now, why should we still get vaccinated? Is the question you probably are holding in your mind, right? If we're not able to prevent transmission of the Delta variant in vaccinated folks, should we still get vaccinated? And the answer to that clearly is yes. And we want to point out then the why behind that yes, which is 88% effectiveness against hospitalization, right? And 91% effectiveness against severe illness is what Israel has reported, is what we're seeing reported from other clinical research, and is the reason why we should still get vaccinated. Again, going back to the chart that we presented earlier, right? When we said if we were talking about increasing cases in isolation, then the conversation would be different, right? But we are seeing increases not just in cases, but actual deaths, meaning that, right, we don't have enough people vaccinated to prevent a spike in cases of mortality, right? So that is the goal, not only for preventing spread as a result, spread and morbidity, but we want to prevent deaths. And that is the reason why we should still get our population vaccinated, okay? Going back to where we were previously here, real quick, we want to zero back then on what Israel was reporting and why this information, though, is a little disheartening in regards to our ability to get to a point in which we don't see a high transmission rate of COVID-19 amongst vaccinated individuals. So let's zero in on Israel. Israel is important because they lead the world in fully vaccinated individuals. We talked about that and looked at their success at the end of last year, the beginning of this year, at their vaccination campaign. And at this point in time, they have a total of 62.19% of fully vaccinated individuals, okay? Canada leads in terms of total number of vaccinated individuals, but as you can see in this diagram of the light shaded green, they don't trump they don't lead Israel in fully vaccinated shares of individuals. So it's important to point this out because they are close to that 70% mark that we referred back to Hawaii reopening, right? Why is that 70% relevant for discussion still? That was the number that we in the clinical community felt comfortable suggesting for some type of herd immunity protection for the workforce and for the general population, right? Recall that. That was before Delta. That was before we understood that we have a variant now that is resistant to vaccination, meaning can escape immunity from a vaccinated individual. And so as we begin to unpack that and the impact, we can now see clearly, again, going back to the chart of daily new confirmed cases per million, that Israel is experiencing a similar spike to the United States, even though they lead the world in fully vaccinated individuals, very close to that 70% mark. So this is undergirding that even with a highly vaccinated population, COVID transmissions will still occur as a result of the Delta variant. But again, what we want to look at, and we'll look at this we'll perhaps look at this next month, is look at the trend of deaths in Israel, right? Because again, the reason to get vaccinated is to look at the death rate or confirmed deaths in a population as it pertains to new deaths and whether or not the vaccination efforts can positively affect or cause a decrease in those fatalities. As we know, there is about a 30-day lag time, 2-week to 30-day lag time from spikes in COVID cases to deaths. That's why we'll be examining it on the trend in Israel as we talk next month. So let's look at now then kind of the interventions beyond COVID, the why, right, of why we want to mandate the COVID vaccine. Why are we now seeing, and you know, if we're observing a trend of vaccine mandates, one, is it true, right? Can we have real examples of mandates out there in the marketplace? And then secondarily, why? Why all of a sudden might we be seeing these mandates coming to fruition that we've long debated over the last several months? And so, yes, the answer is clear. You've seen it probably in the headlines, right? Large organizations like Walmart and Disney have mandated COVID vaccines in the workplace, right? And if we look at specifically what they've mandated, Walmart has mandated for their nearly 1.6 million employees, right, that and nationwide, that they need to be vaccinated if they travel between locations, right, or if they work in multiple facilities or campuses, all office campuses, associates, right? Vaccinated by October 4th is what they've mandated. As we look at then Walt Disney, they took it more expansively and said everyone, right, who works for Disney, that's including ABC, theme parks, and other studios, need to be both salaried and non-union hourly employees need to get vaccinated in 60 days, right? So that's far-reaching in regards to these organizations saying we mandate the vaccine in the workplace, hands down, right? And so as we look then at other trends in the marketplace, we've talked about it before, we'll talk about it here again briefly. Well over 150 universities nationwide have now required for the fall semester, if you're going to be on campus, a mandate for vaccinations. Okay, and this list continues to grow. And so with this trend of required vaccinations, both in the private sector and in the universities, we can understand now a little bit more why we may be seeing this trend if we look to what was published recently here in July, which is a opinion from the administration, in this case, the Deputy Counsel to the President, Acting Assistant Attorney General's Office and of Legal Counsel. And specifically what they've said is, and we won't go through the entire document. Obviously, if you want to read the 45-page legal opinion, go for it. I know colleagues that have, and I've gone through quite a bit of it as well, but we want to focus in on what they concluded. At the end, they concluded, after examination of several factors, that the code, section 564 of the FTC, this is regarding FDA, does not prohibit, right, public or private entities from imposing vaccination requirements, even only when the vaccination are available in a EUA fashion, the emergency use authorization. So that was the litmus test for companies, private and in the public sector, to pass for the requirement of vaccinations in the workplace. So we'll be looking to see, as this trend is likely to continue in the marketplace, which companies and how they implement it, both which companies, the why and the how, right, to protect the workforce. But we want to talk about how briefly we can achieve this other than the straightforward mandate, right? is there a way to be a little bit more creative around these type of mandates in the workplace? And so as we lead in with a health-focused mandate for the workforce, we believe that will play more and be more receptive to the workforce than a simple, we're gonna mandate the vaccine, right? We want to make sure we're focused in on that total health, total worker health mindset, and leading in with that is the goal for our communication to the workplace. But in terms of the how, let's learn a little bit from what we saw play out in an organization that didn't quite mandate the vaccine, but in a way put in place measures to help promote vaccination. And if you haven't guessed, we're talking about the NFL, right? So what the NFL has said specifically is that teams will forfeit games if they can't play due to a COVID-19 outbreak in their organization. And specifically, they said that the amount of NFL players, right, needs to be promoted. And so if you're unable to play, the games that will be forfeited if they can't be rescheduled will result in that 18-week schedule, will result in, for both entities, a situation where the team will not get paid and the players won't get paid, right? And so it's a double penalty, even if it's only one team that is unable to play because of a COVID outbreak. So we see a creative way in this organization to not require the mandate, right, or require the vaccine, but still put in place consequences that result in, likely in this case, a increase in vaccinations to not negatively, so that their organization is not negatively impacted financially. And so we can learn from that in many ways in regards to the financial success of our organization being tied to the health and wellness of our workforce, right? And we spoke to, again, preventing absenteeism, even preventing presenteeism if you have individuals that are ill, unfortunately, in the workplace, right? And we want to make sure that we continue to be creative in how we package and how we put together, how we execute on increasing the number of vaccinated folk in our workplace. So the messaging, again, we can be creative with it, but we want to emphasize that COVID is a long-term event. This pandemic, as we're seeing it proven out, is going to last for years to come, very likely, right? We know that we're again identifying other variants that are of interest and other variants that have new potentials. But we want to emphasize to our workforce that because COVID is here to stay, we want you to protect yourself, protect your family and your community. And that longevity of the pandemic certainly brings about the question, right, which will be part of the messaging because the questions are starting to arise from the workforce that have even been vaccinated already. When are we going to need a booster? Right? If the variants are here and they're going to continue to resurface, is my family at risk? Am I at risk if we've already been vaccinated from a new wave of and new spikes of infection? So let's touch upon that briefly here. So if we look at what CDC has published back in June, there is guidance now around when boosters will be required and how they will be required. We don't have time to go through all of these in detail here, but in summation, we're estimating that boosters will be required at a minimum, right, of 6 months, likely to be 12 months, because we know that there is a waning of vaccination efficacy after you've been vaccinated. And we know that the results from the safety trials of a booster with Pfizer have been beneficial and no untoward outcomes at this point in time. So as we look at the trend in nations, Israel was one of the leaders to begin giving boosters to those vulnerable over the age of 60 because of the waning immunity as a result of the Delta variant, right? And recall Again, Israel being the most successful at fully vaccinated percentages of their population, began early administering the vaccine, meaning they have a significant number of the population that are at that time scale for a booster requirement, right? So we'll continue to follow this because now we have a swath of U.S. healthcare providers that were amongst the first responders to receive a vaccine who are coming up on their 12 months after being vaccinated here in the U.S. And we'll likely see more trends of this, not just internationally, but here in the U.S. in terms of when to give boosters. Now, with that being said, today, WHO has called for a memorandum, a moratorium on booster shots, right? At least until the end of September. And if we look at the reason why, it's so that we can reach globally at least 10% of the population in every country to be vaccinated, okay? And so that is why the WHO has come out and said, can we please internationally hold off on booster shots until the end of September at least. We'll see if there's a response, what type of response there is to that messaging from the WHO. Certainly here in the US, we have not seen any trends yet of boosters being given, but certainly we'll be reporting likely on that trend this coming month for this talk here. So with that being said, we're going to save a good chunk of time here for answering your questions, and we will jump right into it. Thank you.
Thank you so much, Dr. Harris. And we do have quite a few questions, so I'm going to take them, maybe not in quite the order received, but attempt to cover all of them. The first question is there a number of attendees for a group gathering, like a conference, that could serve as criteria to help define exposure risk? In other words, could we allow different risk management protocols depending on the group size, say 10 or 100 or 1,000 people? In all cases, we would assume we don't know the vaccination status of the attendees.
And say the first part of that question again, just to make sure I didn't miss it here.
That they're asking about, is there a risk profile or protocol you could have that depends on the size of the gathering you're having?
Certainly, got
assuming
it.
that people aren't vaccinated, like you don't know whether they are or not.
Sure. And so if I can rephrase the question as well, just to make sure I'm fully understanding the question. You know, at the end of the day, should we have a different approach to a gathering of 10 versus a gathering of 50 versus a gathering of 500 as it pertains to protecting those individuals from transmission risk, right? And so early on, perfect. And so we can look back to our approach when we didn't have a delegation or a subset of the population vaccinated, right? That approach, obviously, from the administration, CDC, on down was limit the gatherings, the number of people at your gatherings. And the reason why is all tied back to our R naught number, right? The reproductive rate of an illness, which is a predictor of risk of transmission, and it is predicated on population size, or we can say in this case, in a microcosm, the size of your gathering. So the number of contacts an individual has at any given time increases the risk as their number of contacts go up for transmission. And so, yes, we can very easily conclude that a greater number in your gathering would impart a potential greater risk for transmission as a result of the R naught calculation, right? So now the root of the question is, do we apply different guidance for protecting that particular size in a particular gathering to help mitigate risk? In this case, we'll assume we're talking about the workplace. And so it is reasonable it is reasonable from a numbers standpoint to suggest a difference in approach for various sizes and various levels of risk in the workplace. But from a practicality standpoint, we've seen it not play out well when there are different protocols for different population subsets in large workforces, right? So if you have a population or a workforce with several thousand individuals, having 2 or 3 or even 4 different messaging around how to protect yourself, depending on your actual scenario that day or that month, right, can be complex, complicated, and lead to poor compliance. And not because the will of the people to be compliant is low, it could be just for a matter of confusion in messaging. So we've been very dogmatic around what one size fits all type of approach to our workforce recommendations because of the simplicity in communicating that. Now, we've seen a divergence only with the vaccinated population in messaging, right? That's from CDC on down. Those who are vaccinated don't need to wear masks indoors, outdoors. Now that risk level has now increased because of Delta, we've seen that now change in recommendation, right? CDC now recommends, if you're indoors, recommends only to wear a mask. Doesn't mandate you have to wear a mask, even if you're vaccinated, just recommends. Those who are unvaccinated still obviously mandating, hey, you need to wear a mask at this point in time. So because of that, the complication and of complexity of messaging and ensuring compliance, we would suggest to have a one-size-fits-all approach for your workplace guidance. Again, not taking into account the individualized messaging for a vaccinated population versus unvaccinated, since the question specifically mentioned that would be an unknown for population size.
Okay. Next question is about testing. If your staff is fully vaccinated, should you still test PCR or antigen for COVID on a regular basis? And if so, how often should you test?
So from a surveillance standpoint, which is what the question sounds like it's suggesting, should you have a surveillance testing program for a vaccinated population? And at this point in time, there is no data to suggest that a surveillance program for a vaccinated population is effective at preventing transmissions in the workplace yet, right? And it's just because we haven't seen the studies in that regard. But we know that surveillance for an unvaccinated population is effective. So therefore, if we get to a point where transmission risk in a community is similar to what we saw for even vaccinated folks because of the Delta variant, or in this case, the Lambda variant. And I realized I didn't include the slide that I meant to mention, so I'll take this moment to present that. The Lambda variant now has demonstrated resistance to vaccination, right? So the Lambda variant is now increasing in its prevalence in several countries. We'll report next month on its prevalence here in the US, but just recognize that there's another variant that's already showing resistance that may be even more resistant than the Delta variant that's starting to surface. So that ties in well with the answer to this question, that if incidence in the vaccinated population arises to the level that we saw previously with unvaccinated individuals or nears that, then surveillance would become very likely an effective tool in that scenario. At this point in time, that's not the case yet. So testing only with at-risk individuals who have had either a positive exposure, even regardless of vaccination status, or are symptomatic should be your approach at this time.
Okay, and I know we've covered this before, but with things changing so quickly, we'll ask it again. What is your guidance on domestic travel for vaccinated people?
So this, we've seen actually, if we look kind of trending amongst the employers that we service here at WorkCare, we've seen those companies that have said, we're going to dial back conservatively on domestic travel as the number of cases have increased in every state at this point in time, except for Kansas. And we've also seen those companies say, look, we'll only continue domestic travel if you are vaccinated, and put in a mandate that if you're planning to travel, you must be vaccinated. So that is a reasonable approach to help mitigate risk for transmission, but recognize the most conservative would be obviously reducing your domestic travel back to what we saw last year, which is for strong business necessity only. And as we see Delta continue to spike in the US, we are likely to see that trend towards limiting domestic travel from a safety standpoint. Now, it's not to suggest that we have any data to show and demonstrate that air travel is more risky as a result of Delta variant. We know that Delta variant is far more transmissible, right? We spoke to that earlier in the presentation, 60%, but we haven't seen any studies regarding Delta and airline travel because masks are still required at this point in time for airline travel. We're likely to see transmission rates continue to be low, even with the new variants, because of the protective factor that we've seen be tremendously successful with air travel in the past regarding wearing masks.
Okay, I'm going to combine two questions from the same person, but I'll try not to make it too confusing because I'm combining them. The first question is, do we have a better understanding of what COVID-19 is as a disease? For example, what systems does it affect the most? What types of comorbidities result in the worst outcomes? And then the second half of the question relates specifically to COVID brain and the percent of Delta variant cases where the patient's experiencing COVID brain as opposed to the Alpha variant. But she recalls it was about 30% of adults who were experiencing COVID brain originally.
Sure. So to take on the beginning of that question in terms of COVID effects on the physiology or the pathophysiology of COVID, this takes us back to our webinars days of old, over a year ago. It affects the vascular system tremendously. We know it affects obviously the respiratory system, right? But the poor outcomes result in obviously death, right? The respiratory system being overwhelmed, and at the end of the day, respiratory failure. We've also seen, because of the microvascular effects of COVID, end organ damage from kidney to liver, obviously brain being one of them. Stroke was a phenomenon we saw early on, and it all was attributed to hypercoagulation or coagulation in the blood vessels itself because the platelets would glom together, right? And so as we fast forward to the second portion of that question regarding the COVID brain in particular, it is likely, well, all the pathology looks like now at this point in time, it's because of the microvascular in the brain from specifically cells called megakaryocytes that are sitting in vessels in which they normally don't exist. And they're causing the vessels in the brain to be essentially clogged, right? And that can lead to the deficits in memory, the fogginess, trouble with recall. And I have not seen any updated literature pointing to Delta variant causing an increase in COVID brain or an increase in coagulopathy as a result of a COVID infection. Now we're seeing similar rates for sure in regards to those who are being hospitalized from Delta variant, those who are have severe cases being in the ICU. And so it's likely to have a similar profile in regards to COVID brain. And yes, up to about a third of people are reporting to have some type of COVID brain effect. If we look back not just at COVID-19, but back to Middle Eastern Respiratory Syndrome, MERS, and SARS-CoV-1 back in 2003. And that's something we spoke to before because it's under-recognized likely that particular impact as a result of a COVID infection.
Yeah, okay. That's a great explanation. Thanks for that. With a couple of questions regarding vaccination for children under 12. What's the status of the vaccination testing that's going on with children and when we think a vaccine might be made available? And do the statistics on total vaccinations include those that have been used in pilots on children?
I'd say the second part of that question again, just to make sure I understood it correctly.
For the statistics showing the total percent of population fully vaccinated, does that include children who have been in pilot tests, or is it just adults or teenagers?
Got you. So we can look at that specifically, right? When will we anticipate children under 12 being fully rolled out? FDA has said midwinter, right, of this year. So we still got some months to go, and that was reported back in mid-July, where FDA said expect midwinter for under 12. If we look at the data then for populations under 12, CDC is not reporting that data, right? It's only being reported from the clinical studies. And as you can see on your screens now, when we talk about the percentages, we're looking at the population over the age of 12 because that is the lower limit for our vaccination efforts in the US thus far. Hopefully that answers all the points of that question.
Yeah, I think so. Thanks. Two questions are going to ask, and we have about 3 minutes left for those of you who are still hanging in there. We all know, and we knew, that vaccinated folks can get COVID and pass it to others. Why are they not required to wear masks?
Sure. So the mask requirement or repealing or pulling back the mask requirement, if you recall, came at a time in which there was a lot of COVID fatigue and a lot of economic stress, right? And so the guidance that we saw for vaccinated individuals to not have to wear masks came from data that suggests there was a likely 95% chance, right, that individuals who were vaccinated would not transmit COVID-19, right? So it was a low percentage estimate that would still be able to contract and transmit. Now, efficacy around prevention of severe symptomatic illness was that figure. And again, we didn't fully understand to what extent transmissions would occur for vaccinated individuals that were protected from symptomatic disease at that level, at that high percentage, right? And so that's why we saw easing of the mask restrictions for vaccinated folks only. Obviously, anecdotally here in Chicago, right, we know the vaccination rate here in Chicago. And I can tell you, going out to the restaurants and to the different venues, certainly with Lollapalooza being here this past couple of days, that the percentages of vaccinated folks did not match the percentage of people not wearing masks. Hence the spikes that we're seeing, the spikes that we've seen now in terms of transmission. So I believe because of that, that's why we're seeing businesses going back to mandating, venues going back to mandating. Certainly the language of CDC has changed to suggest that it's prudent to wear your mask even if you are vaccinated. And now we certainly have the data to back that up in regards to the Delta variant being, not being more resistant than the Alpha variant to the vaccination.
Okay, we have just time for one more question. So for those of you we can't get to, Be sure to check the Q&A. Oh, shoot.
Did you lose the Q&A? I can pull it up if you have.
No, my computer just shut down. Can you still hear me?
Yep, we can hear you.
Sometimes it does that. All of a sudden, it always happens during the webinar. It must be one of Murphy's laws. The Q&A will be posting as soon as we get it transcribed. So Dr. Harris will answer the remaining questions in writing, which we have customarily done for every webinar. It's actually a great little library of information because we did 52 in a row and now these monthly ones. So let's just ask the last question. In the case where staff are mostly working from home and or unvaccinated, should they wear a mask in the office? And oh, sorry, I'm not reading it right. In the case where staff is mostly work from home and are unvaccinated, wear a mask in the office. How relevant is a vaccine mandate in the workplace?
Sure. So the vaccine mandate should be in place if we're taking into account that total worker health mentality, right? That not only is our role as EHS professionals to help protect workplace risk, but also protect overall health risk impact to the business. Therefore, individuals who are unvaccinated certainly are still very much at risk of severe illness, poor outcomes, and death, orders of magnitude greater than someone who is vaccinated. And that's why we're suggesting that no matter what, mandating a vaccine in the workplace is the right thing to do if we're talking total worker health, right? And so that's why we want to shift to that mindset and hopefully get our leadership on board that, and even, you know, the study, not the studies, even the articles, the opinions that we see coming out. I'll refer you back to what Walmart, the opinion around Walmart, right? The free market has spoken clearly, vaccination mandates are good. And earlier in the article, it says good for, it says it at the top, right? Vaccine mandates are just good for business. So I think we can lead the way and the voice and back it up with data to show, for example, we'll present this next month too, an individual in the workplace who contracts COVID-19 on average, if they are a poorly controlled diabetic, will cost nearly $70,000 in healthcare costs. If they are a well-controlled diabetic, that goes down to around $29,000, right at $30,000 in healthcare costs. If they don't have diabetes at all and have significant symptomatic disease, it's down to only $16,000 in healthcare costs. So for our self-insured employers, again, mandating a vaccine that can limit the impact of a COVID-19 infection amongst your workforce is good for total worker health and good for business. That's why we say we recommend it no matter what.
Okay, great. Well, we'll look forward to that a month from now on chronic disease management and cost savings. So that wraps up our session. Thanks again, everyone, for joining us and staying for the full hour. We always love seeing you. It's always good to hear from Dr. Harris. So stay safe. And if you have any questions at all for us, please send them along to info@workcare.com, and we'll be happy to address them. Thank you, Dr. Harris.
Thank you, everyone. Stay safe. And as always, God bless.